Greetings, my brothers and sisters in Tanzania. This is Dr. Gwen Randall, and I am so excited to have the opportunity to come to Tanzania to share with you my skills, my knowledge, my talents, in hopes that we can impact the outcome of women who are suffering from postpartum hemorrhage. Our learner outcomes would be more importantly is that we would have early recognition of postpartum hemorrhage, that the right interventions would be applied, and that the patients would be managed to a point of delivery to a higher care facility, or that we would be able to arrest the bleeding to get them there. And we're also going to be able to demonstrate the use of cognitive aids. There is a California Maternity Quality Care Collaborative. It's out of California, and they have basically put together a consortium of hospitals, and these hospitals were funded, and what they decided was that there was such a big problem with morbidity and mortality with hemorrhage. So these hospitals got together, they formed this consortium, and they developed toolkits. How can we make things better? How can we standardize care across the continuum? And so with them being able to pull together and developing all of these different tools, they were able to decrease morbidity and mortality among women with hemorrhage by 20.8%. That is an astounding number. And so a lot of the information that I'm going to be sharing with you have come from them, from this consortium or collaborative, if you will. And the interesting thing is that it's all information that's free. You can use it freely, and they have all kind of toolkits that you can use, and information can be reproduced or disseminated for educational purposes. So I am utilizing their skills and their talents to share with you. When we talk about maternal health in Tanzania, there are 566 maternal deaths for every 100,000 live births. That happens to be the 6th highest maternal mortality ratio in the world. What are some of the challenges that are faced? The challenges are that there is inadequate quality of services, there's a lack of access to emergency obstetric care, and limited ability of women to independently access the health systems. Obstetric hemorrhage remains a leading and preventable cause of maternal mortality and severe maternal morbidity. It is a life-threatening complication of pregnancy. But again, if recognized early, treated early, it doesn't necessarily have to be a death sentence. So when we talk about the causes of hemorrhage, some of these slides are going to be redundant from either lectures that I've already done or some other lectures that you've heard already. But redundancy is good, okay? So the causes of maternal hemorrhage would be 70% of the time it's tone. The 20% is trauma, 9% is tissue, and then 1% is thrombin. But majority of it is tone, urine. So when we think about patients coming on to our units, what kind of information do we need? Well, first of all, we need to do a risk factor assessment. We need to evaluate the patient for risk, and we'll talk about those in a minute. Do they have an antibody screen? Are we able to identify that? Do they have prenatal records? Did they have prenatal care at all? And then be able to identify if these patients are going to decline blood, what is going to be our next plan of action, and to always ensure readiness. Because what we can say is every patient that comes through the door, every mom who's pregnant come through that door could be a potential postpartum hemorrhage. So the hemorrhage bundle, if you will, is organized into 4 domains, and they're called the 4 R's. And the 4 R's is readiness. Every unit should be ready. You should have a hemorrhage cart, hemorrhage medications, a team, and how you're going to manage the blood. We should always be able to recognize what is going on, do a risk assessment, and then if the patient is bleeding, to be able to evaluate the blood loss and then activate management. What kind of response do we have? Every hemorrhage, we should have a stage-based emergency plan. Support programs for patients and families, and then we should have some kind of reporting system to identify what the weaknesses were, what the outcomes were, what could have been done better, and what kind of changes should we be making in our system. Again, every pregnant patient could be a potential postpartum hemorrhage, and I can't stress that enough. So when a patient comes onto the unit, it's really important to start to do an assessment on these patients in terms of their risk. Are they high risk, low risk, or medium risk? And as you can see here, as identified, low risk basically would be routine obstetric care. Patient has 1 pregnancy, she has less than 4 vaginal births, and she really doesn't have any kind of bleeding disorder or PPH. A medium risk would be, okay, the team should be on alert because the patient has had prior C-sections. Are we going to allow this patient to VBAC, to try to deliver vaginally, or has the patient having multiple desiccations? Has she had more than 4 vaginal births? Does she have a history of postpartum hemorrhage? Does the patient have fibroids? What about her labs? So those are all the kinds of things that we're going to take into consideration when we determine a patient to be at medium risk. High risk, everybody should be on alert. We should consider anesthesia, should be in attendance at the delivery. The patient should be typed and crossed. Blood should be readily available because the patient has some known entity, placenta previa, low-lying placenta, abruptio, or patient has a known coagulopathy. Also, the patient could have low platelets, hematocrit is very low, or the patient could already be suffering from fetal demise. Forehand knowledge really will make a difference. Having ourselves readily available for these patients should the patients, anybody who's identified especially as high risk. So the maternal hemorrhage, again, we had low risk. Again, we need to take into consideration the levels of risk for these patients. If these patients are low risk, then, when our patients come in, the patients already have like an IV, we put in an IV, not necessarily that we're going to run it, but at least to have a map done. The patients is a lot of times on the units, if the patients have if they're on units where they have residents all the time or anesthesia 24 hours, then those patients are really evaluated at time of admission. A patient should have type and screen on board and make sure if the patient is going to decline transfusions, what is our plan of action for that? Medium risk, we already talked about. We should review whatever hemorrhage process that we have available. And anybody who's high risk, that patient should be typed and crossed. We should have blood available. We should have the drugs available. We should really have a hemorrhage cart readily available as well. And anesthesia needs to be actively involved. It's interesting to note that up to 40% of patients who experience postpartum hemorrhage have no identifiable factors. So here we did, this is the Society of Medicine, and so here they identified actually the undeliverable hemorrhage risk and then delivered hemorrhage risk for these patients. So undeliverable factors are there as you've seen, and it's pretty much reiterating what I've already said, but they have broken it down to further whether patients delivered, whether a patient is not delivered. Again, here's a delivered hemorrhage risk assessment, low factors, medium factors, and high factors. And then here's the postpartum hemorrhage risk assessment factors. Low risk, the patient will accept blood or the patient will not accept blood. That's the bottom line. Medium risk, the patient, you notify the provider, make sure that the patient will accept blood, have a type and screen available, and you should have drugs readily available. In high risk, anesthesia should always be involved, and preparation should be made in the event that the patient has a hemorrhage. We should have high risk, all action items are validated as complete. So what are some of the triggers? So stage 0 is at all normal births. Stage 1 would be a trigger because the blood loss is greater than 500 for vaginal delivery and greater than 1,000 for a C-section, but the patient is continuously bleeding. They have signs of concealed hemorrhage, which can validate or manifest itself in the vital signs, okay, and some confusion. Stage 2, the patient is continuing to bleed. At this point, we're less than 1,500 mLs, but the vital signs are still not normal. So we have stage 3, where the grade of blood loss is greater than 1,500 mLs. 2 units of plaque cells should be given. Patient has abnormal vital signs. There's some suspicion of DIC. Vital signs are trending towards abnormal early on compared to the patient's baseline. So a patient who's febrile, tachycardic, especially after a C-section, should be considered a concealed hemorrhage, and it could be also consistent with endometriosis. Vital signs that really are not responsive to the usual assessative measures, then the patients can become confused, they're lethargic, pain is unrelieved, and then the patient just circles down the drain. According to the American College of Obstetricians and Gynecology, ACOG, and ACOG in the United States is pretty much our standard. Those are the ones who sort of make the standards in terms of what should be done. They also publish guidelines, and so around in the United States it's pretty much uniform in terms of how people behave and what people do based on ACOG standards. Do not wait for laboratory results to begin. If you suspect that the patient has a hemorrhage, or the patient is showing signs of a hemorrhage without you being able to quantitate the blood loss, do not be afraid to begin a transfusion. So the question is, are you prepared? Are you prepared for an emergency should an emergency happen? So some of the things that we're going to talk about right now is blood loss. There are many different ways to do it, and so many times we are behind the 8 ball in terms of what is really happening and then versus what we actually see. When we do an EBL, or estimated blood loss, essentially what we're doing is case by case. You have multiple observers, and then you're just kind of quantitating what's in the sponges, what's on the drapes, what's in the container, and it tends to be underestimated so many times. As a matter of fact, there was a study that was done that said anywhere from 24 to 44% of the time that, when you ask people about blood loss, the blood loss is really underestimated. So that's not necessarily a good thing. Quantitative blood loss is by gravimetric technique, and the blood is actually weighed and subtracted the dry weight. So in other words, you would have a pack of sponges, could be 10 in the pack. You weigh those sponges, and then once the patient starts to bleed or you start to see blood loss, then you would subtract the volume, or you subtract the weight of the sponges from the blood that you're getting. It's much easier, if you will, to use scales, and scales should be available, but if they're not readily available, they're pretty easy and pretty cheap to buy. You can also do the volumetric method, and the blood loss is actually observed in a container, and you subtract the volume representing amniotic fluid or irrigation. The quantitative blood loss measure is like coloremic, if you will. The blood loss is determined by a device, and that device actually scans the containers and estimates the amount of blood. There's actually a system that we use here in the state that does that for us, and it goes by, it's as estimated by the sponges. The cumulative blood loss is the term where everybody seems to communicate that the patient's blood loss, it should be visible in the patient's electronic record. And it's a combination of the EBL and QBL for the events. Here is just a picture of, and a reference, if you will, pictorial reference of and guide for the estimation of blood loss and blood hemorrhage. As you can see here, if you have a soiled sanitary towel, it's like 30 cc's. If you have a small soaked swab, it's about 60 cc's. So if you have a full kidney dish or kidney basin, it's about 500 cc's. Anytime you see blood spilling onto the floor, you know you have at least 2 liters. Blood in the bed, but not necessarily draining down to the floor, could be in excess of 1,000 mLs. Again, on the second side, you see the same pictorial thing where it says a maternity pad fully soaked is 100 cc's, and then you have the large pads, you had vaginal pads, and then blood overflow again. If you have blood overflow from the bed, then you know that you are in serious trouble. I would really be careful with visual estimation because, again, it's very inconsistent, it's underestimated, and large volumes of blood are lost before we really know what's happening. So to be ready and to recognize potentially what is going on with the patients. So as we talk about readiness, I just wanted to put a question out there to find out, do you have a cart? Do you have a hemorrhage cart on your units? And if you do, then as you can see here, there's a checklist of things that really should be part of what's in the cart. There should be recommended supplies for IVs and a bunch of other things, as you can see. If the patient has to have a hysterectomy, that tray should be in there, as well as scissors. Anything that you would need in an emergency really should be in your hemorrhage cart. The medications should also be in there. So there was some question about whether or not pharmacy should actually be heavily involved in when these patients have hemorrhages, because there could be some inconsistency in terms of the medications that are available. There could be some inconsistency with who's really delegated to check the hemorrhage cart. And if you're in stage of fight or flight at the time when all this is happening, then you may need another person, and who else could be better to assist you with drugs than the pharmacist? So you might want to consider having a pharmacist as part of your response team. There's been some new TXA recommendations. TXA is basically, there was some literature published, and there was a large study that was done, and they said that there was some question about whether or not you can infuse TXA and oxytocin together, but there is no compatibility issues, and so that is really not a problem. So TXA is pretty much used for refractory atonic bleeding or persistent trauma related to bleeding. However, what's being said now, and even by WHO, is saying that really TXA can be given up front, give it early to arrest some of the bleeding prior to getting yourself into trouble. So it comes in 1 gram per 10 mLs, or it comes in 1,000 in 100 mLs. It can be infused over 10 minutes as undiluted drug. You can give a second dose of 1 gram if the bleeding continues in 30 minutes, and then if the bleeding stops, and then you can also restart it within 24 hours after completing the first dose. Now, initially there was you give the second dose in an hour, but now basically the recommendation is that the second dose be given within 30 minutes. Here is information, the medications that should actually be in the hemorrhage cart, and I won't belabor you with those dosages and all that, because you know oxytocin is always the first line, and then the others are depending on whether or not the patient is hypertensive, if the patient has hypertensive or hypertension or not. Sorry. There are no clear recommendations for oxytocin dosing regimens. Some people use it prophylactically. If you don't have an IV, then you give it 10 units IM if there's no access. And then it's always administered as first-line treatment. We do 30 in a bag, or you can put 10 to 30 in 500, or 20 to 60 in a liter. It just depends on the preferences. But we really should avoid high doses of oxytocin infusions greater than 30 to 40 cc's per hour. When we're in the OR, especially if it's C-section, we just open it and let it rip. That's what we do, the oxytocin bolus. This hemorrhage cart should have a binder on the top of it, and information should be in that binder. So things like consent forms, who's on call for OB, for GYN, whether or not you have an ultrasound machine, and it should be a quick reference for things like dry weights and QBL, etc. Stanford University has done an amazing job of developing cognitive aids, and they recently published a book of cognitive aids, and it's for OB, and I'll share that with you later in the presentation. So the next question is, if the patient is continuously bleeding, what are you going to do? Do you have a massive transfusion protocol? And if not, why? And the thing is if you know that you don't have blood readily available, then how are you going to treat this patient? Early recognition is very, very important. Early activation is very important to have some kind of support and correct any kind of underlying problems, and then to be able to continuously repeat your assessment. What kind of labs does the patient have? How does the patient present? And if the patient is responding to your treatment or not. So when we talk about mass transfusion, if a patient has a volume of 10 to 15% loss, their vital signs are going to be stable, okay? They may have a little hypotension. If they have 15 to 30% of their blood loss, BP may be slightly decreased, but the patient at that point could become somewhat tachycardic. They're starting to get dry, they're thirsty, and they could be weak. When you get to 30 to 40% of your blood volume, then basically you're going to see a drastic drop in your blood pressure and your vital signs. You're going to see some confusion. The patients may clamp down, they may not pee, skin color can change, and 40% of their volume pretty much ends up in death. So we really don't want to get to that point. Uterine balloon tamponade. It's recommended for treatment for situations where you've already done all the urotonics, you've done the TXA, where urotonics are contraindicated, and basically everything that you've done thus far has been ineffective or unavailable. So where is this tamponade? I can't tell you. One time I was on call and we had all new nurses on night shift, and the patient was bleeding out, and the surgeon started yelling for me, "Gwen, I need your help, I need your help." I'm like, I can't take care of anesthesia and the patient too. He said, but I need you to help these people out. So if you're going into a room and you're working with a team, know who that team is and what their capabilities are, and everybody should know where these balloon tamponades are. If you use them properly, the success rate is like 68 to 88%. They should be placed with ultrasound guidance for the most beneficial outcome and reduce complications. So here's a question for you. How many of you have cognitive aids that are readily available and accessible in your units? Cognitive aids are cognitive aids are used in medicine, and what they help people to do is to piece information together so that it enhances your cognition and adherence to the medical best practices. So for an example, if you are in a craft situation, sometimes you don't always remember and someone can be calling out, but why should you be put in a situation where you forget something and then basically could cost a patient their lives? So these cognitive aids are simple pieces of paper, sort of like a written reminder that if something is complicated, it can be interactive and dynamically changing all at the same time. So therefore, you have these aids. You can have a checklist that goes with them, and so you don't forget anything when you're going through these different drills. Oh. In 2015, Cronbach published that 34% of healthcare providers feel comfortable relying on their own memory when dealing with emergencies. In 2013, Arriaga, he said that cognitive aids reduce errors during OR emergencies by up to 75%. Cognitive aids increase adherence to evidence-based practice care. They reduce the error rates and increase provider satisfaction, and that was reported by Hegeman in 2014. Mulroy in 2013 says it is time for healthcare providers to use cognitive aids during emergencies. One of the things that we use here in the States are flowcharts and checklists. So when a patient presents, as we've already talked about, this just puts everything in perspective. When the patient comes in, a patient is admitted, what is the category and what is the risk of that patient? Based on that information, you then go down to the different stages. If a stage 0 should be a normal delivery, as we discussed before, and the standard steps with those would be, basically if the patient runs into trouble, then you do active management of the third stage labor with giving the patient just oxytocin. The triggers for this stage would be if the patient starts to lose blood greater than 500 cc's, greater than a liter, then there are some clues or cues that we already discussed previously. Okay, so then if the patient's blood loss exceeds normal, then it's a question: is it yes or is it no? Then it's stage 1. Stage 1, what are the steps for stage 1? So if you look at the steps on the side there, what are the actions that are associated with all of these different stages? And when you are doing your simulation experience, then you're going to be expected to know the stages and know the treatments for those stages as you go through the simulation. So the things that we're going to be looking for is, 1, did you identify the risk? Is the patient low, medium, or high? Is the patient bleeding or not bleeding? If the patient is bleeding, what stage is the patient bleeding? And from that stage, what steps are necessary for you to, go into action so that you can be on top of the situation before it gets out of hand. The next one is The next slide is, again, an emergency management flow chart, which again just identifies what we've been talking about is pre-admission, time of admission, the different stages, the risks that are involved, and the certain behaviors that are expected. How quickly do we get the patient to the OR? How quickly do we identify that the patient is bleeding? How quickly do we administer drugs? I mean, it's all really about time, because time is bleeding, and bleeding and bleeding plus bleeding equals death. So we always want to be in a position where we're able to call for help and have the drugs readily available, i.e., again, going and having your OB hemorrhage cart readily available, so you're not fumbling around trying to find things. The other thing is that when you're doing these OB emergencies, you should always know who's on first, who's on the team, who's going to be the team leader, who's going to be in charge, and you can go down the checklist. So we'll be using checklists during our simulations. And so the things that I want you to be familiar with definitely are your management of the patient, your flow chart, how you're going to progress from A to B, and also to do your hemorrhage checklist. Now, this hemorrhage checklist here is step by step. What do you need to do initially? If you're stage 1, again, stage 1, the blood loss is greater than a liter, and the patient still has normal vital signs, and the patient may have about 500 cc's. So the initial steps is, does the patient have an IV? Does the patient have fluids? Does the patient have a catheter? And fundal massage, okay? So what medications are appropriate during this time? Those are the medications that are on the side. When do we give PIT? How much do we give PIT? When do we give Methergin? How much Methergin do we give? And someone should keep record of exactly what's been given, just like if you're in a cold crisis situation. So what action do we normally take? First of all, we want to determine the etiology and be prepared to treat. We want to have the OR always ready, if indicated, to take that patient back to the OR and do what needs to be done. Was there big tear? Was there retained POCs? Is there coagulopathy? Those kind of things we want to be able to identify. Stage 2, okay, now the patient is up to 1500 cc's. We've given urotonics, and they really haven't worked. We have lab values. So what steps are we going to do? At this particular time, you're going to call for help, okay? Patient should then have a second IV, draw labs, prepare the OR, and then continue the medications. At this time, TXA is certainly a consideration, and maybe even earlier on, if the patient is not doing well, stage 1. Do we have blood available for these patients, and what actions are we going to do? Okay, if the patient is continuing to bleed, we've done uterine massage, bundle massage, and now we're at the action. Do we need to place a balloon? Okay, if we need to place a balloon, then who's available for that? Is the OR ready? And considering basically moving the patient to the OR and get control of the bleeding. And so TXA and the possible interventions on that side, as you can see. And then stage 3 is the patient has already received 2 units of cells. We've mobilized the help. Her status is deteriorating or maybe not. What kind of plan are we going to communicate? Is this the time the patient needs to be transferred out? Do you have a massive transfusion protocol? If not, who is calling to prepare this patient for transport? And those are the kinds of things that we want to keep in mind, because time is money. Money is how quickly are we going to get this patient out of our facilities or out of the facilities, and then transfer those patients to a higher level of care. So if the patient crashes, has a massive hemorrhage, patient's shock, has an emboli, then what are the things we do? Well, doing ACLS, we also use cognitive aids. You hear in the States, Stanford Stanford University has already done a great job of using cognitive aids for ACLS as well. So now we're at the point where, okay, the patient is still bleeding. We really want to try to arrest the blood as much as we possibly can. And so we're going to be using the NAS garment, or non-pneumatic Anti Shock Garment. Is considered to be a first aid device that assists women in survival. Basically, when there are any kind of delays in transport, and before they can actually receive definitive treatment. Well, this intervention, there was a study done in Zambia, and basically with the intervention of the NAS garment, then it resulted in about 45% or 54% reduction in deaths and morbidities. And so it's really a very, very good device, because the studies have demonstrated that 25% of those individuals who came in shocky, then those individuals were able to recover much earlier than those who did not receive the garments. And so, with that, hopefully we're going to be able to use the garments, and also to be able to leave garments at each facility. We're going to have practice runs on how you put them on, how quickly you can get them on. And so these garments actually compress the lower body, and it's 9 articulated segments that you put close tightly around the legs, the pelvis, and the abdomen. And so what happens is there's a circumferential compression that decreases the vascular volume and leads to an increase in preload and PVR and cardiac output. So essentially, we're tamponading off the vessels to reduce blood loss. This is a picture of how the garments are placed. They're placed in a very systematic manner, 1, 2, 3, 4, and 5. And then when they're removed in a very systematic manner too, with time delays in between them. Now I have a video of how the garments are placed, and it's about 11 minutes or so, and this is will be the end of my presentation. So the expectation is, number 1, that you will be familiar with the checklist, because that's what you're going to be graded on during the simulation. Secondly, you need to be familiar with the with the grid of what you need to do. You need to have some familiarity with the stages. And so the things that are in this presentation are the things that we're going to grade you on, and evaluate you on, especially because if you're going to go back into your respective communities and teach this, then you have to have some familiarity, and you have to know where to go and go back and set things up and be able to act and react very quickly. And so I hope that this has helped you. But if you have any questions or concerns or anything like that, you can feel free to email me at Gwenny, GWENNYJCRNA@gmail.com. And you can also WhatsApp me as well on the WhatsApp. So I thank you very much for listening, and I hope that this presentation has been helpful to you. But remember to study hard, and I'll see you soon. I think it's about 10 days now. All right, thank you. Bye. I have actually incorporated the STANFORD OB manual. It gives you some introduction. It was developed at Stanford University, and it gives you some idea of how to handle OB emergencies. It's a very comprehensive document, and I hope to, or we hope to, at least have one for every hospital, and then you guys can then, if you need to, make more copies. This manual should be part of your OB card. The other thing about the NASG garments is that they need to be stored in a place where everybody knows where they are. And there's also a process on how they should be cleaned. And if they go with a patient from one hospital to the other, the receiving hospital should have a clean pair of these NASG garments for them to take for the other transferring hospital to take back with them. Make sure they're kept clean, and make sure that everyone knows where these garments are. There was a suggestion on one of the presentations, one of the workshops, to say that perhaps they could be put inside the OB cart. I'm not sure, but there should be some place readily accessible in the OB suite that if you need them, you know where to run for them and to get them. The other slide is just information on what's actually in the cart. I'm sorry, what's actually in the what's actually in the OB manual. And I have given you the, down here, I have actually given you the address where you can possibly access it online yourself and then possibly download it. So you can download it so that it can be printed and stored and bound, or you can have your own personal copy. Now, simulation is a very big part of having people work in multidisciplinary teams for effective response, and the purpose of debriefing the critical incident. What went right? What went wrong? How can we improve on our care? There is not in simulation, we don't blame anybody for anything. We just work together as a team to make things better, to have better patient outcomes. So we're going to be addressing issues. Were the issues in practice? Was there issue in transportation? What exactly happened, and what do we need to do better? And so it's very, very important to have all the key players who are involved in caring for these patients, nurses, physicians, pharmacy, nurse practitioners, whomever usually is involved, to be a part of these drills that we will be doing. And so after the simulation is done, it's very, very important to debrief about the incident, to talk about how we performed. Were we in the problem-solving mode? Were we acting in real time? Should we change our practices? And if we change our practices, how do we change our practices? And so after all is said and done, if a patient is perhaps transferred to another facility, then we need to find out how that patient fared, how the transport went, and what were the deficits that were used. Can we upgrade the system? Can we make things better so that we can decrease the morbidities associated with these patients? And so we need to have a communication plan. This communication plan is for meaningful learning and subsequent process for improvement for the clinical team. It's extremely important to function as a team when we have these different events that come. Postpartum hemorrhage, codes, any of those kind of things. We always need to know who's on first, and someone needs to be in charge of actually delegating to different people. I want you to do this, you to do that, so it's not a whole big chaotic situation. What kind of processes do we need to change after we go through this whole scenario, and after you've had a case? You can have some samples of cases that you've done. What kind of policies and procedures do you have in place? Okay. First is, do you have a risk assessment? Does every patient get a risk assessment? Do we have a measure to quantify blood? Are we debriefing afterwards? Do we have hemorrhage staff education? What kind of training do we do with the nurses and with the medical staff basically during the course of the year? It shouldn't just be one time, it should be a couple of times. Are we keeping current actually with all of the things that are coming down the pike so that we can change? Even though the government may have a sample of what you should be following, then as advanced practitioners and physicians and educated individuals, then we can take a look at, does this work? Could we be doing things better? And then maybe have some dialogue with the government and say, okay, well, things are really changing. Could we change this if that's the necessary process that you need to go through? But identifying the patient, identifying the fact that the patient is bleeding and acting quickly is really part of the big process in terms when we go back and look at how things went. What was the outcome of the patient? We should be doing outcome measures, should be monitoring. What kind of QI process do you have in place when these things happen? Do we have cases? What cases do we have? The cases, are they severe maternal morbidity? What actually happened? Did we have to use massive transfusion? And if we did all those things, then what now do we have to think about in terms of how we can do better? Did we have blood available? If we didn't, did we use the mass trousers? So we should be evaluating any of these cases that come into our facility, especially if we have to transfer these patients out. We need to find out what kind of complications the patient had, and was the patient shocky? Did the patient survive? All of those kinds of things. We should be keeping those kind of statistics in our facilities, because that's the only way that we're going to improve and do things better, and have better patient outcomes, which is the ultimate goal in all of this. Have our processes in place that we can help the patients to go from point A to point B and survive the ride, as well as survive the trauma of the event. And here are the references, which you can go online and look at any of these references and kind of use them to take a look at what you're doing and if some things could possibly be changed. The one thing I would say is when the patient comes to the unit, the patient should be evaluated by anesthesia, because once the patient starts to go down south, down the tubes, if you will, then sometimes it's very difficult to start getting two large bore IVs in. But if you have a map where the patient has IV access, doesn't necessarily have to have fluids running, and you know that that IV is patent, then basically you're a little bit ahead of the game, and you can at least start some crystalloids on the patients until you can find other things. So just being prepared. I can't really express that enough to you, but preparedness is really the key for these patients, okay? And if you're prepared, then you should have better outcomes. So thank you.